Hello, kidney warriors. James here from Dadvice TV, your online kidney health coach. And this is episode number 318 of Dadvice TV. And we are live right now on Thursday, October 24th, 2024. Had to think about it. I almost said the year wrong. And we are going to be talking about some amazing, brand new information about drugs and treatments that are out there to help slow the progression of kidney disease. Now, for those of you that are new, welcome. Great to have you here. We love to build our audience. Here at Dadvice TV, we stick with facts and science and what is proven, what is real. There are tons of scams out there, and Dr. Rowe, my co-host, is going to talk about some of them, but I want to summarize it real quick. If you see somebody selling a pill or some kind of supplement or something like that that's going to fix your kidneys, it's not real. It's not going to work. Kidney disease is treated in all the countries around the world, and it is so expensive. They spend so much money on it. The first person who finds some magic fix for it, they're a trillionaire. They're going to save all the country so much money. They're not going to be hawking pills $100 for a bottle on Facebook or pushing out newsletters and stuff like that, trying to get you to buy their fake cures. So just remember that. There is no cure, but there are things you can do to help put the brakes and slow the progression of kidney disease in many cases. And we're going to talk about that in tonight's show. Now, my co-host is a regular here every single month. He comes on, he talks about great topics, brand new stuff that's happening out there. He's a nephrologist. He's got experience. He has written so many papers. He's written a great book called Learn the Facts About Kidney Disease. If you have kidney disease, this should be the book that your doctor hands you. It's going to take away so many of the worries. It's going to help you to understand, this is what I need to focus on. This is what matters. And there's a whole section in there that talks about when is the right time to start dialysis, because too many people are starting it too early. And the data shows that starting it early for those people, for most of them, is not necessary. All right. So that is Dr. Rosansky. Let's go ahead and let's bring him on. Hey, Dr. Rowe, how you doing?
I'm good, James. I'm good. I'm glad your voice is a little better than last time because
Way better.
I had to do all the talking, but anyway, yeah, I'm glad you're better, and I'm very excited to tell your viewers about some really exciting stuff. And I guess you generally want to introduce me and let people know my credentials. I am a kidney specialist. I am retired. I still see patients though in the free clinic, and I've taken care of kidney patients over 40 years, and I've written over 100 different peer-reviewed publications. And one of my most recent publications relates to today's discussion, and that came out very recently in a journal called Kidney International. And if any of you would like to ask your docs about that, you can, and they can look me up, Dr. Steve Rosansky, look up that article and see what it's all about. And tonight I'm going to discuss some of the aspects of that. I'm going to try to make it understandable, just like I tried very hard in my book to make sure you folks can understand some of these complicated issues. And whenever you're ready, James, we can dig in.
We are ready. But before we get in there, I'm going to go back to the screen with you and let everyone know there's a QR code up there in the corner. If you scan that with your phone, if you're watching this on your computer, a laptop, or a tablet, and you scan that with your phone, that will take you to Amazon, where you could order Dr. Rosansky's book if you don't have a copy of it and you like to get one. It's a fantastic book, and I encourage everyone to have a copy of it. All right, Doc, let's go ahead and let's get started.
Okay, so we're going to talk about game changer drugs. And what do I mean by game changer drugs? Well, we've waited decades to get something that will help people like you folks out there with kidney disease deal with the progression of your kidney disease and deal with, very importantly, the associated risk of getting uh, heart attacks and strokes. What we call, the big word is called atherosclerotic cardiovascular disease. And that is a big risk for people with CKD. CKD is a risk factor for that. So the thing about the drugs is that a lot of people can't afford them. They're very expensive. And the question is, should you go out and spend your money on these drugs? And who should get the drugs and who should probably save your money? And the classes of drugs, and you can go back. There was a one of the Dadvice talks about the game changer drugs. I may have been last year when I first introduced them. And we've got a lot more information about them now. So I refer you back to that first talk if you can find it on Dadvice website. So the drugs, I don't know, James, do you happen to know what they are by any chance?
Well, there was, okay, so I got to remember all the categories. Well, we had the regular ones, the ACEs and the ARBs. We had the SGLT2s. We had the GLP-1s. And there's two more categories.
Well, there's really just one, and that's the category of the drug that you take, the spironolactone, which is an.
It's a hard one. It's like I can't remember.
Aldosterone antagonist. These are big
That's
words.
it. I mean, tongue twister.
Okay, so we're going to focus tonight on the SGLT2s. The SGLT2s. You can know if you're on one of these drugs if they have a name of the generic name called gliflozins, empagliflozin, canagliflozin. The other game changer drugs are what James mentioned, the GLP-1s. Those have gotten a lot of press. Those are the weight loss drugs, but they also have benefits for kidney patients. And we're not going to discuss that tonight. I'm going to save that for another Dadvice talk. The GLP-1s are the glutides, like semaglutide, and a lot of folks have heard of Ozempic and Wegovy. So that's the GLP-1. And the aldo antagonist, the one that came out recently that's very expensive, is called finerenone. And those of you who are on it will be having the brand name Kerendia. And there's not a lot of research on that, and I will probably just briefly mention that tonight. We're going to focus mostly on the SGLT2s, which are really, really big game changers. We're going to talk about when they're recommended. So, excuse me, I'm like you last time, James.
You still have a voice. I had very little voice and a lot of coughing.
All right. So, the SGLT2s and the GLP-1s, they're great drugs for diabetes. And they first came out for diabetes. And then we found out all kinds of other benefits for these drugs. The GLP-1s, as I said, are the big time obesity drugs. And they've had an enormous impact on people's problems with weight. Huge impact. And then there's another really, really important factor for these drugs. They help people that have weak hearts, called congestive heart failure. And they can decrease deaths. This is very important, from all of the problems related to heart disease that patients with kidney disease are at higher risk for: the heart attacks, the strokes, and the blood vessel diseases to the legs. All three of the drugs, the GLP-1s, SGLT2s, and the aldo antagonists like the finerenone, they all can have an impact on slowing decline of kidney function. The best data and the most data on this is the SGLT2s. The finerenone, if you're on it, it's called Kerendia. There's not a lot of data on it. I know a colleague of mine was very involved with that study. I mean, the results are impressive, but nothing near the amount of good data that we have on the SGLT2s. And that's the one that we'll focus on tonight. And there's about, well, first of all, those of you who know anything about science, you know that the most important thing you can do to study something is do something called an RCT. You know what an RCT is, James? Should we tell your guests?
I do not know what an RC it repeatable.
RCT, randomized
Ah,
controlled trial. And most of these are placebo controlled. In other words, roughly half the people get the drug in question, roughly half the people get a placebo, and you can really determine if the drug is doing anything. And there are 11 really good trials out there on these SGLT2s involving 81,000 patients. So a
wow,
lot
that's
of patients.
huge.
It's a lot of patients, really good studies. And the news is great. These drugs can decrease having problems with the kidney, and they put a lot of problems that you could have together. They decrease the various problems by 40%. That's a lot. So
Mm-hmm.
there's an effect. There's a real effect for your kidneys. And some of these things that they look at, they're called endpoints. They're including getting kidney function below 15, which a lot of docs and call it kidney failure. And unfortunately, they start pushing dialysis, which, if you read my book, a kidney number of 15 is high to be starting dialysis. Starting dialysis closer to 5, which they do in a lot of countries, certainly Asian countries, with good results, and also Australia and even the UK, they start much closer to 5 to 10. So those of you who are being pushed to go on dialysis in the 10 to 15 or 15 plus range, please get my book, discuss it with your doctor. So the endpoints, one of them is less than 15. Doubling of creatinine. What does that mean, James? If your creatinine doubles, what does that mean?
Your estimated kidney function, EGFR, has dropped.
By, if your creatinine doubles,
I don't know. Is it linear? It's not linear, is it?
yeah. So, okay, you folks out there are getting a kidney number called an estimated GFR. It's going to be on your lab sheet. And that kidney number is primarily determined by the creatinine, which is just a marker that they use to see how well your kidneys are functioning. And the way it works, if your kidney number it's in the denominator, if that doubles, your kidney function goes down by 50%. Okay, so that's what they're looking at. And one thing that's really important, what they say, it's not just that your kidney number doubles; they want to see it sustained.
Mm-hmm.
Why do they say, in order to show that the drug worked, they want to show that, the people who didn't get the drug, how many got a doubling of their kidney number, and it was sustained. You know why they put those words in? It stays low. It stays, the creatinine, the GFR stays 50% decline.
Is that to weed out the natural fluctuation of the GFR?
Perfect. Perfect. So many of you are going to be hearing about anecdotes, and I'll talk about one of the people that pushes something and uses anecdotes about people's GFR going from 60 to 54 and say, oh, I cured this person. These numbers vary a lot, day to day, month to month, week to week. And that variation is not due to your kidneys getting worse. So they want to have it sustained, okay? Or going on dialysis or getting a kidney transplant. I mean, that's obviously a serious endpoint. Now, these drugs, the SGLT2, they were first designed for diabetes, and they did a great job. They were great diabetes drugs. As a matter of fact, a lot of diabetes docs and even the kidney organization are saying a lot of you take metformin for diabetes, but it's probably as good as metformin. It's a really good drug. But they found out that in addition to treating diabetes, these drugs had great benefits for your kidneys and for your heart and for your survival. So they are game changers. These are really big drugs. So they reduce deaths. And this is so serious because no one wants to die early. And these drugs can decrease your risk of dying a heart disease death, especially if you've already got some heart failure. These drugs are great to help you live longer. So, well, let's get into the meat of the discussion tonight. A lot of people are saying, oh my goodness, these drugs are so expensive. I can't get insurance to pay for it. It's going to cost me a fortune. Do I really need them? And that's what we're going to address for you tonight. This is important. And as I said, I recently wrote this article in Kidney International addressing this. And I'll tell you a couple of things that I talk about in my paper. Everybody can understand this. If you are a pharmaceutical company, you want to get one of these SGLT2s or GLP1s. These drugs are massive money makers, massive. All of these companies are racing to get these drugs and push them on as many people as they can. And most of you out there are CKD stage 3. What is CKD stage 3? James, do you know what that is?
It is a GFR above 30 and below 60.
In that range, exactly. And again, us kidney specialists decided that we're going to try to put these kidney patients into groups, and we made these groups by different numbers of your kidney, different ranges of your kidney number. So why would you suspect, James, that people with CKD3 may not actually benefit enough to spend the money to get the game changer drugs that are very expensive?
Well, first, very few people who are stage 3 make it to where they need dialysis. So taking the drugs and the expense may not be necessary. And then I want to throw in also, for some people, especially those that are been more matured through life, the older folks, a lot of them that are at the top of stage 3, and they don't have any protein or urine, maybe it's just their normal kidney function for their age.
Perfect, James. You're right on it. And the last point that James made is extremely important. And countries like Australia, New Zealand, they do not consider you to have CKD if you are over 70 years old and your GFR is above 45 and you don't have protein. Okay. And that's going to be a large number of you viewers. Okay.
That
The other
just took the worry off of a lot of people's shoulders.
Yeah. Well, I mean, some people will accept it. Some people will still worry. But That's what a lot of experts are saying, that your age, as you age, you lose everything. You lose brain cells, you lose heart cells, you lose kidney cells. And it is expected, as long as you don't have evidence of damage in your kidney, and the biggest way to see damage is showing protein in the urine or blood, but protein more importantly, then you probably got normal kidney function for your age. The other big point, and James is right. I mean, roughly, most of you are CKD 3A, and they divided up CKD 3 because it's a large range, 30 to 60 is big range.
Mm-hmm.
So they said 45 to 60 is 3A. And if you are over 70 and you don't have protein, 3A may not really be applicable. You may not have kidney disease. But if you're younger and you're 3A, it is extremely unlikely that you're going to ever need dialysis or a kidney transplant. Maybe 1 in 1,000 to 1 in 10,000. It is very unlikely. The other thing is, most people with stage 3 don't have a lot of protein in the urine. And roughly only 1 out of 10 of you are going to have significant protein, which we're going to get into. And the original studies on these SGLT2s, they required patients to have some kind of diabetes, heart disease, and a protein level of, we'll get into it, albumin, creatinine, protein, albumin, and creatinine of over 200. I'll discuss that in a minute. Now, the other thing is, the business of medicine wants to promote and push the drugs that are new, because that's how they make their money. And there are a lot of drugs that are generic and are very cheap, including spironolactone, which is a cheap version of the Kerendia, the finerenone, the aldo antagonist that I mentioned earlier.
You know, I just got my prescriptions refilled over the weekend, and that one was just over $4 with insurance for a 90-day supply.
Yeah. I mean, you're not going to get finerenone or Kerendia for anywhere near that kind of money. Now, so there are drugs that you should be on if you're a kidney patient and you've got high blood pressure. There are drugs that have been shown since 2001, over 23 years. These drugs have been around. They've been shown to help decrease your deaths from heart disease and potentially slow decline of kidney function, especially in diabetics. Diabetes is the number one associated condition with people going on dialysis. Roughly half of people that go on dialysis have some relationship of diabetes to their kidney disease, called diabetic kidney disease. And it's been shown that the ACEs, which end in what, James?
You can okay, I get them mixed up. One's Prill.
That's the ACEs.
Yay!
Prill, lisinopril, and enalapril. And the other is the ARBs, which end in tan. Like losartan, olmesartan. Okay. These drugs may decrease your going on dialysis by 40, 50%, especially if you've got a lot of protein in the urine. You got to get these drugs to start out with. They're cheap and they're important. So you should be on those to start out with. Unfortunately, a lot of people that are diabetic are not getting these drugs. It's been estimated that only 1 out of 3 are getting them when they really should be on. So don't let your doctor just push all these expensive new drugs on you. Get the cheap, older drugs because they work. They've been shown. There's lots of research on them, and use those first line.
And you can have you'll end up with a combination of these, right? It won't be just an ACE or an ARB. You're going to start with that and build on.
Now, you don't take both. You take one or the other. And if you've got significant protein, which we'll get to in a minute, you want to get the maximum dose of either an ACE or an ARB. And then you could add these newer drugs. And again, it's not likely that you're going to require a dialysis or transplant, especially if you're 3A, even if you're 3B. 3B would be 30 to 45 GFR, your estimated kidney number. The main goal for most of you is not to say, oh, I'm worried that I'm going to need a transplant or go on dialysis. Your main goal is what? For most people, especially with the 3As and even 3B, what's your main goal, if you don't have much protein, is to do what?
For me, it's manage my blood pressure, keep that in check, and then do all the healthy things. Stay active, don't smoke, etc.
What you're doing is kidney disease is a risk factor to get a heart attack or a stroke, and blood vessel disease. And as James said, you want to do all of the things to decrease that risk. That's your main concern when you are at high levels of kidney function, meaning 3A or even 3B, without a lot of protein. That's your main concern. Now, if there are things to slow progression, and we talked about it, it's the ACEs and the ARBs, but good blood pressure control, as James mentioned, is a extremely important thing for you to do to get your blood pressure to goal, roughly 120 to 130 on the top number. That will help you from getting kidney failure. Diet will help, and that will also help you decrease your risk of dying from these heart and blood vessel problems, strokes and stuff. And a plant-based diet, which is very good. And I think, I assume Jen discusses that a good bit.
Oh yeah.
And I am
and plant-based does not mean vegetarian. It means you're including or starting with the plant-based things, and you may have a little chicken and things like that still in there.
I'm all for that. And I have to now digress a little bit on tonight's topic.
Oh, now you're going to talk about the bad guy?
Because there's way too much misinformation about being on these very low protein diets to slow progression. And there are people promoting books, promoting something called keto analogs. These are things that you have to take when you're on very low protein, or you'll get severely malnourished. And an individual who sells these things, who's got some books out there, who's basically poo-pooing plant-based diet, which is ridiculous, and saying that the keto analogs and very low protein are what you need to do. That's nonsense. And he's saying
it's his keto analogs that he sells. It's those.
Of course. And saying that the kidney organizations are recommending very low protein diet. Not the case. Not true. Let me tell you what, there is an international kidney organization. You can go on the internet and you can look them up. They're called KDIGO. K as in kite, D as in dog, I as in igloo, G as in good, O as in on. Look up KDIGO. There's an enormous amount of information out there. And I've been involved with their guidelines over the years. This is the top kidney specialists in the world. Listen to them, not some non-physician that's going to talk to you about anecdotal stuff related to what he's trying to push. What does KDIGO recommend? They say that you should eat about a third of your weight in protein. So if you're 150 pounds, which is not many of us, is 50 grams, 210 pounds would be 70 grams. What's the average protein we take in? That's a relatively low protein. What's the average protein that?
It's probably closer to 100 grams, or I'm going to guess.
120. So if you're you're roughly 200, 210, 70 grams, that's a relative restriction. That's all you need to do. And what the very low protein diet is talking about 0.2 grams per pound. If you're 200 pounds, 40 grams protein. That's unpalatable and it's dangerous and it's crazy. And what the international kidney docs say, if you are at a high risk, meaning you got massive amounts of protein in the urine, and you could be under close supervision, maybe only then. That's the only time they say it's unpalatable. It's horrible tasting diet, and it is dangerous, especially if you're an older person, because what happens as we age, James? Remember what we talked about?
Malnutrition.
We lose muscle
Yeah.
mass. You will lose muscle mass. And that's why I go to the gym every day, to try to keep my muscles intact, because the higher your muscle in your body, the longer your longevity. It's a very strong predictor. And if you're on low protein, how do you build muscle? You need protein.
Mm-hmm.
You can't do it without protein. And if you don't get enough protein, you're an old person, you're going to have weak muscles. You may fall. You may wind up in a nursing home. I mean, this is serious stuff. Please don't fall for that very low protein diet. Now, what matters, and we mentioned it already, for progression is the urine protein.
Mm-hmm.
Okay? How do we measure urine protein in the urine? Do you know, James? We briefly mentioned it already.
Well, it's a urinalysis, and they do the ratio, the albumin creatinine ratio, ACR.
Perfect. Oh, so people say, what about protein in the urine? Why measure albumin? Albumin is the main protein in your blood. And rather than measure all the protein, most docs have moved to ordering a urine test where they measure your urine albumin and your urine creatinine. And that ratio is what will define whether you've got mild, moderate, or severe protein in the urine. Now, these are rough categories. Mild would be less than 30, moderate 30 to 300, severe over 300 in that albumin creatinine. And if your doc is not doing it, tell them, I heard that that's the most important thing for you to be measuring. I'm a kidney patient. I heard this from Dadvice, from Dr. Rosansky. Please tell me what's going on with my urine protein. Now, a dipstick, and we've talked about the fact
Mm-hmm.
that those of you who want to can buy them on Amazon. There's urine dipsticks that measure protein. If you are consistently over 1+ or more, if you're consistently in that range, you've got significant protein. So that's a cheap way to determine it and to follow it. And as I said, okay, now I have to tell you folks outside the US, we are weird. We use these weird things. We don't use, actually officially we're on the metric system, but we never use it.
We're on the metric system a lot more than people realize. You go and you buy a 2 liter of soda, your car engine. We got the Mustang V8, 5.8 liters.
Yeah, and I mean, some of the signs are in kilometers as well as miles. So if you are outside the U.S., divide those numbers by 10. So it's 3 is mild, less than 3, moderate 3 to 30, severe over 30 if you're outside the U.S. Now, having a lot of protein is unusual, especially at 3A. It becomes much more common if you get to be below 30. If you're stage 4, like 15 to 30, many more people are going to have significant protein in the urine. And older folks, much less common than younger folks to have a lot of protein in the urine. So, who should pay and who should be pushing for the new drugs? And remember, again, if you are one of the people with significant protein in the urine, make sure your doc has you on an ACE or an ARB, as we mentioned before. Now, we're going to focus on the SGLT2. Here's my thought. The drugs were originally for diabetes, and a lot of insurance companies will cover the drugs if you're diabetic. And if the drugs are going to be covered and you're diabetic, by all means, they can treat your diabetes, they can potentially help your kidneys, and they can potentially decrease your risk of death from, as we said, from heart attacks and strokes and things like that. And so even if you're not having a lot of protein in the urine, I would say it's a reasonably good thing to try to get on and discuss that with your doctor. And the International Kidney Organization recommends it as well. If you don't have diabetes, you don't have significant protein in the albumin in the urine, significant proteinuria by that albumin to creatinine ratio, and you don't have heart failure, you haven't had a heart attack, you haven't had a stroke, and you're especially CKD 3A or even 3B, probably not worth the money. Probably not worth the money.
Yet, unless you progress down eventually.
Unless you have protein in the urine that's significant. And that's a good question, James. If you are now at stage 4, I would say, even if you don't have protein, that's a good point you bring up. If you're like James just said, if your kidney function is to the point where you're below 30, I would say that these drugs may be worth the money. I'm not for sure, maybe. Why am I hesitating to push them for everybody? And I discussed this in my article in Kidney International. There's something called an acute effect. Does that ring a bell to you at all, James?
Is that where it's a temporary, like when some of the medications drop your GFR for a little bit?
Yeah, James, you got it. You got it.
Hey, we've been doing this for years, Doc.
You got it. You got it. And I have dug into that issue. Okay, so let me tell you what James is talking about. Most of us kidney experts will tell you we call it the party line. What is everybody saying? They're saying, hey, these drugs are known to maybe initially cause a decline in your kidney function. Okay? And that's pretty scary. And what we experts have said, and I don't know if it's with really good reason, is that even though you may have an initial decline, and a lot of docs stop the drugs, they stop the ACEs, they stop the ARBs, you may still have a long-term benefit in slowing kidney function loss. And even more importantly, of dying from heart disease. So the issue is, and we would say 30% decline. That's a lot. And we don't really have a good handle, and that's what this Kidney International thing I discussed. It's really complicated. We don't have a good handle on looking at how to interpret that initial decline for the overall picture, and way too complicated for your audience. And you got to realize that most of these studies are not going to be long-term. I mean, they're usually 3 years or less. And they're not going to wait for people to see who goes on dialysis, who doesn't. So I think that there's good enough reason, especially with the ACEs and the ARBs. With the ACEs and the ARBs, there have been studies to show that those folks who stop the drug because their kidney function declined a little bit when they first started, they did worse. They did worse in terms of kidney loss, and they did worse in terms of heart disease. So we've got some data to suggest that we know what we're talking about. That even though there's an initial decline, it's still worth staying on the drugs. And these drugs have been studied in people that are at high risk of having heart attacks and strokes, and people with diabetes that are already at a higher risk. And they're life-saving, potentially. And if you got significant protein in the urine, it's worth the risk of that acute effect. But if you don't, I would say it's something that I don't think you should be spending your money on if you are not one of these people that has heart failure, that has had a heart attack or a stroke, that's got significant protein in the urine. That short-term decline, in my opinion, may not be worth you buying these drugs. If you are at risk, that short-term decline, long-term benefit, I think, is worth you getting these drugs. If you are, like James said, maybe if you're already CKD4 less than 30, or you've got a lot of protein in the urine, or you already got some heart attack or stroke, or you've got heart failure, decreased cardiac function. Now, one of the things that I have read about is that a lot of docs are worried about giving it to older folks. And I'm an older folk. Older folks are over 70 or over 75. Hard to
I
tell.
love that the number keeps moving as I get older.
Yeah, definitely over 70. For me, it's over 80 because I'm going to be 78. So,
Wow.
so it's over 80. But anyway, some folks would say over 70. But they're safe. They're safe even if you are an older folk. And a lot of older folks are going to already have some weak heart problems. They may have already had a heart attack or a stroke. So don't hesitate to get them if you're an older person. And I've talked about this on this show before. If you've got kidney disease and you're getting treated for diabetes, there is a danger of getting low sugar called hypoglycemia. It's a real dangerous, potentially life-threatening thing. But the study showed that even with these newer SGLT2 drugs for diabetes, you're not going to get any more hypoglycemia than the placebo. So these are serious studies, placebo versus drug, right? Dummy pill is a placebo. The other thing that docs worry about, what happens when you take these drugs is they pour a lot of sugar out in urine. That's what they do. Mm-hmm. They keep the kidney from reabsorbing sugar that's coming in through your kidney back into the blood. So you pee out a lot of sugar and you can get decrease in your volume. So they worry about that. But that also was no different in people that were on the placebo. So older folks, you got a good reason to take it, go ahead and get them. And I'll try to answer some questions, James.
We got lots of questions, but I'm going to bring in a comment that Lisa Jackson just wrote after you mentioned your age. She wrote, "OMG, Dr. Rowe, you look great."
Thank you.
And I hope when I'm your age, I'm just as active and going to the gym, and because I plan to be traveling the world. So I want energy and going out and seeing things and just having a great time. But there's tons and tons of questions in there, Dr. Rowe. If you want to search through them,
okay,
and see which ones you would like to respond to.
Excuse me, I apologize. I got a little bit of laryngitis myself tonight.
And I'm surprised no one has noticed. I feel like you and I are in sync with coughing too.
Oh,
I hit my mute button and I cover my mouth, but you're coughing at the same time.
Oh boy, yeah, we've got great sound effects tonight.
Yeah.
So I'm there's a lot of people are just telling what's going on. Jennifer starting on the transplant list, and Diane as well. So I'll tell you a couple of things there. This is not today's topic, but worth mentioning. Um, if you are a patient with a GFR in the 20 range in the US, you are eligible to go on the transplant wait list. If you are a relatively young, whatever that means, relatively healthy, you don't have a lot of other diseases other than your GFR in the 20 range, get on the transplant list early because the wait time is years. And the more time you accumulate, the more likely you're going to get the next kidney that comes up. Someone's asking about pro-renal D
Oh yeah,
vitamins.
I take that, and it's a renal multivitamin. It's recommended by all of the uh, dialysis centers, the National Kidney Foundation. It doesn't have the things that we need to be careful of, like if you go to the store and buy a Centrum, but it's just a multivitamin with some extra vitamin D.
Right. Yeah. I think that if you're on dialysis, you probably are going to need the vitamins because they're removed by dialysis. And the ones that are dangerous are vitamin A and E. They can accumulate in kidney failure. So that's why these vitamins that for kidney patients make sense. If you're not on dialysis and you eat well, you probably don't need them. And the issue of taking a lot of vitamin D, that's a whole nother discussion
Mm-hmm.
having to do with something called parathyroid gland, which gets overactive with kidney disease. There's a debate about taking too much vitamin D because it can raise your calcium high and potentially affect your blood vessels in a bad way. So I'd say if you're eating well, you probably don't need to be taking vitamins because they will just be going out in the urine. But I'm okay. James is taking them. I think it's probably fine.
Yeah, they're recommended by both my doctor and my renal dietitian. And the group that creates Pro Renal Plus D, they're in Ohio. I see them at every kidney walk and kidney group. They're very supportive of our community, which is fantastic.
James Schrager is 75 years old, a creatinine of 1.47 over the last 5 years, and that's
Wow.
I would say roughly 1.5. But it's a great example, James, that
Yep.
that creatinine and your GFR is 52. It averages. This is beautiful,
Yeah,
and this
that's fantastic.
it's a great example. James is asking me, should I be on the drugs? And when is the time to say goodbye to my nephrologist, if ever? James, that's a great question. Let me start from the last part of your question. The kidney organization, the International Kidney Organization, does not recommend you to see a kidney specialist unless you got CKD4 less than 30. Okay. They don't even recommend because there's so many people, as we've discussed, that have levels around 50, like you, that, and especially without, again, significant protein in the urine, it may or may not be kidney disease. You're 75 years old, as we said earlier, and you don't really need to see a nephrologist according to the international kidney organizations because the nephrologist would be way too busy if everyone decided they had to see one when they were in that range. So, real good question. um, does Monjaro hurt the kidneys? Okay, so that's one of the GLP-1s. And it doesn't hurt the kidneys. As a matter of fact, as we will discuss in a future talk, it may actually help the kidneys help patients lose weight and potentially have a benefit for heart disease. A lot of good stuff out there. There's an enormous amount of money being spent because these drugs are gangbuster drugs. They're making, for, as a matter of fact, what is it? Novo Nordisk, I think that company, which is in Sweden, I think. I mean, that company is probably has got more profits than the whole GNP of the whole country. It's enormously profitable. But anyway, not to worry. It probably can benefit. You can certainly take an SGLT2 if you're not diabetic. As a matter of fact, they are recommended by the International Kidney Organization for people with kidney disease that have decreased ejection fractions, some kind of cardiovascular disease history, and if you've got significant protein in the urine. But again, you got to be on the other drugs first, the ACE or the ARB, and then the SGLT2s. Great, recommended. Don't have to be diabetic, and we'll discuss this in another lecture. Some people are pushing taking all of these newer drugs. I would say the first drug of the three that I would recommend, diabetic or non-diabetic, for the reasons that we discussed earlier, would be the SGLT2s. Okay.
I have a question I want you to answer. You're going to love it, Dr. Rowe. Several people have asked similar questions. Lynn asked, what's the risk factors of not going on dialysis at GFR 16? And someone else's EGFR is 16, and they're wanting to know, when do they know it's time to start dialysis?
Okay. So I've written extensively on this. I hope you get a chance to read my chapter. I've got a lot of discussion about it because I probably have published more than anyone else on the issue of when to start dialysis. One of my articles was considered the number one game changer in 2011, I think, for my whole nephrology field. And that article basically said that starting early is harmful. Okay. And the patients that seemed to do the best were the ones who started less than 5 GFR. So why is it harmful? Because you can lose your remaining kidney function, which is critical for your survival. It's been shown to correlate well. Whatever residual you got left is very important. We cannot do as good as your own kidneys, no matter what dialysis machine. The main thing, if you're below 15, which is CKD5, it's arbitrary, 15, 16. You've got to be followed by your kidney doc. You've got to have a doctor that's willing to check you out, check your labs, make sure you're not having problems with potassium, which is unlikely until you get very, very low, like less than 5. No problems with your fluids, you're handling them. And bottom line, if there is an issue that relates to your kidneys that can't be treated conservatively with medicines, that's when it's time to consider going on the kidney machine. One of the big things that have pushed people to go on is they may have a little bit of nausea, decreased appetite. Well, that could be due to many, many different things. When you get down lower than 10 or lower than 5, certainly you may lose your appetite. And is that a good reason to start dialysis? Maybe. I wouldn't say yes or no. But the main reason to start dialysis is if you can't control the potassium, you can't control your fluids, you're short of breath, and most of the things we can manage medically. We can manage your anemia, and people with kidney disease, keeping your hemoglobin level above 11, you could do that with the drugs. That'll make you feel pretty darn good. A lot better than
the worst symptom I had was anemia. Yeah. Just being so weak and not feeling like I could get up and do anything. But once that started getting resolved, it was like I got my life back.
Yeah. So yeah, as long as you're followed, my suggestion is you got a compliant patient, 5 or less, ideally, but and get on the transplant list. if you're below 20. Okay. Somebody's asking a normal creatinine, 86-year-old. There is no, the normal creatinine range is somewhere around 0.7 to 1.2. But GFR, again, if you're 86 years old, a GFR that's above 45 or so is probably fine if you don't have protein in the urine. I think FARXIGA is
Farxiga.
is that an SGLT2?
That one, yes. It is dapagliflozin or
That dapagliflozin. Gliflozin. Look at the gliflozins. Yeah, that's what we're talking about, Lizette. That is a good drug for people with kidney disease with decreased ejection fraction, for sure. Heart disease or have already had some problem with a heart attack or stroke. Now, someone's asking a good question. Side effects. Now, very, very few side effects of the ARBs and the SGLT2. The main thing for both of these drugs, the ACEs or the ARBs or the SGLT2s, is that initial decline in kidney function. Other than that, like the SGLT2s, some people it can actually lower your blood pressure, so you got to be a little careful. And some people get a little dehydrated, so you don't want to allow yourself to get dehydrated. The ARBs can raise the potassium, so that's the main problem with that, or the ACEs. So as long as you're getting your labs checked, you're fine. Very few side effects of these drugs.
Got time for one more, Doc.
Oh, okay. CKD stage 4, is that the one we already did? 16 GFR.
Yep. We did the 16s. There's a couple of them.
Well, they're asking about plant-based diets declining function. So the thing about this is 38-year-old with focal FSGS. It's a type of kidney disease that you find out on biopsy. If you got a lot of protein in your urine, your doctor may recommend a biopsy. Now, that particular kind of kidney disease usually has a lot of protein. So you need to be on these drugs that we talked about, the ACEs, the ARBs, and SGLT2. And, unfortunately, that kind of disease may progress despite these drugs. And some doctors would also use steroids. Anyway, are we out of time?
Well, you got through that pretty quickly. If you want to pop in another one, there's actually one that just came in near the bottom from Lisa. It says, "As my 86-year-old mother's caregiver, what should I look for in her kidney ultrasound? The EGFR is 16. So can you talk about someone who's 86, EGFR is 16?"
Okay. Well, look, if you're a male, the biggest problem when you get to be older is blockage of your kidneys from your prostate. That will not happen with a woman. And the reason to do, I'm not sure why they're doing a ultrasound. I guess one reason to do the ultrasound is to see if your kidney problem is old problem or a new problem. You can have something called acute renal failure, meaning you can get a GFR 16 and your kidneys may be normal in size. That will tell your doc that it's so-called acute and possibly reversible. And Sarah asked, how long does initial decrease in kidney function last? Basically, again, if you are one of these people that has got significant protein in your urine, you're at risk protein in the urine, you're at risk for going on dialysis. 30% or less, follow it up. If it's going down more, definitely we would stop the ACE or the ARB.
All right, Doc.
Okay.
Well, go ahead. We are out of time. I know there's so many questions. They start coming in a lot, especially near the end. But I want to mention your book one last time. As you guys saw, Dr. Rosansky is easy to understand. His book is also easy to understand. There's a lot of things we kidney patients worry about that we really don't need to worry about. And when we hear that from someone with authority, with experience, whew, that really helps life, feel so much better while you're living with kidney disease. So if you haven't gotten a hold of Dr. Rosansky's book and you like what you're hearing here, his positivity, how easy it is to understand him, I encourage you to get a copy of his book, Learn the Facts About Kidney Disease. Fantastic books. Matter of fact, I'm going to bring up that QR code up on the screen again. There it is. Dr. Rose there. And there's that QR code. If you scan that, it'll take you right to Amazon so that you can order a copy of his book if you like. It's also very affordable, which is fantastic. All righty. And Dr. Rose here every month. It's usually one of the last couple weeks in the middle towards the third week of the month. Talks about a great topic. This is science-based stuff. This isn't any of the fake stuff that you find out online. There are no cures. Don't fall for it. Put the money in something else. Save it up for a vacation and treat yourself instead of giving a scammer a bunch of money. And he's always here. Also, the first week of the month, we have a renal dietitian, Jen Hernandez, here. And I plan next week to purchase a new computer, which will make it easier. My computer has gotten so old. So I've slowed down a lot because I'm like, oh, well, it takes a lot to keep everything running. Remember, when we started this call, my internet went out as Dr. Rowe and I were just getting connected and started. And I had to reset the router and get everything going. But I hope to have those problems fixed soon. Next week, some new computers will be announced, and I plan to upgrade to one of those. You'll see more and more of me. But anyway, give the video a thumbs up if you like this kind of material. That way, that helps get more attention, helps us get more and more of this. And look at all these thank yous here. Well, we get a bunch of them on the screen because I appreciate everyone being here and writing these comments. And I know you guys all love seeing when your stuff gets up on the screen. It's live. That's how it proves it. All right. Thank you so much. I'll be back in about 2 weeks, right after the election. If you're in the United States, make sure and vote. It's an important privilege that so many people have made sure we have. So let's take advantage and vote at the election. And I'll see you guys all right after that. Thank you, Dr. Rowe. See you next time.
Bye-bye.